Welcome to Unveiling Death. I am Rabbi Jeffrey Weil, the palliative care physician, a conversation with Dr. Tara Coles. Dr. Tara Coles is a double board certified physician in emergency medicine and palliative care medicine. She currently exclusively practices inpatient palliative care for hospitalized patients and families. She is passionate about medical education and promoting well-being in medicine. Tara is also a spouse and mother to 4 children, plus 2 dogs. Dr. Tara Coles, thank you so much for being on this episode of Unveiling Death.
Was my privilege.
Mine too. So I'd like you first to give an elevator speech, and that's always a very kind of strange term because how fast is the elevator and how
Right,
tall is the building? But
exactly.
in any event, can you give an elevator speech? Because I think there is confusion or an ambiguity about palliative care versus like hospice, for instance. So can you explain palliative care or palliative medicine to us?
Yes. I think I first want to explain that palliative care and hospice medicine is a recognized medical subspecialty and has been since 2006. Um, Palliative care, well, the word palliate is to kind of mitigate suffering. And so palliative care is an interdisciplinary medical specialty where a team of physicians, nurse practitioners, pharmacists, social workers, chaplains, volunteers work together to take care of people in coordination with their primary team, medical teams, people with life-limiting and life-threatening illnesses, and can be initiated at any stage of an illness from diagnosis on. And palliative care can be provided along with curative treatments, including, for example, patients, getting chemotherapy. We take care of patients with COPD and heart failure and other life-limiting illnesses. But it is the umbrella term for kind of an extra layer of interdisciplinary support to address the all the different types of suffering and pain that might accompany a patient and their family and caregivers who are faced with life-limiting or life-threatening illness. Hospice, which is often confused with palliative care as kind of the same thing, is a subset of palliative care for patients that either choose or do not have the option of curative or life-prolonging treatments and have a prognosis of less than 6 months. It doesn't mean they are going to die in less than 6 months, but kind of there's a graph of palliative care where diagnosis and palliative care kind of is involved in helping address physical, social, emotional, existential, spiritual, caregiver, all kinds of stress and suffering, alongside with whatever is most important to the patient. So, kind of the basic question that we think of in palliative care is kind of what do we need to know about you and your family and your life in order to take the best care of you possible, and to recognize that that pain is not just physical, but the concept of total pain and suffering involves all of these different aspects of a person's life, and that we are there to kind of show up without judgment to learn about what's most important to people and what their goals and hopes are, um, and to kind of journey and accompany with them.
You use two terms next to each other a couple times, life limiting and life threatening. So is life limiting like, in other words, mortality? Life will be limited because one's mortal, or like life is
Right.
limited because you can't do what you would like to do?
Right. I think it's both. It's both. So when we think about kind of serious illness, I think there's always the potential of morbidity and mortality. But we also take care of people with diagnosis where people have curative intent and are cured or do have serious illness, such as kind of, let's think about heart failure. So people can live many, many years with heart failure, with exacerbations and hospitalizations and kind of maybe a downward slope. but we could take care of them over many, many years. But their illness is life limiting because over time they get more short of breath. They have more hospitalizations. We kind of think of people's symptoms and how they're living their life in terms of kind of functional assessment, like what can they do, what can't they do, what do they want to do, what are they not able to do. So I think the word life limiting can mean just in terms of what your function is in life and how it's affecting what your goals are, and also can mean that things might be changing or transitioning to thinking more about um, how you want to spend the rest of your time, knowing that time might be short. So we often think of when we have family meetings, which are kind of considered the procedure of palliative care. So instead of an appendectomy like a surgeon, our communication and our multidisciplinary and interdisciplinary meetings are kind of our procedure. And we often talk about best case, worst case, and likely scenarios. And that seems to kind of help frame people's questions and expectations into, a set of possible outcomes. So I think that with palliative care, we practice kind of a lot of humility in medicine, where we share in the ambiguity and the complexity and the unknown. Um, and I think that the feedback that I have received from most patients and families is that they're most traumatized by not knowing what could happen than knowing what might happen with compassion and love.
It's tough work, and you see and experience a lot gamut of emotions and gamut of people's health and sickness and agedness and fears and everything else. So what occurred in your background, your own personal history, that perhaps makes you comfortable with something that does not seem like a luxury? I think to most people, they might see it as something very daunting. Why is it not daunting for you?
When I've reflected on this and had to write kind of essays for my fellowship and why palliative care, I think my truth is that I grew up living with my grandparents, my maternal grandparents. My mom and I lived with them. I was also very close with my paternal grandparents. And so living with grandparents, I saw their friends with ailments. I had, family members with progressive dementias, my grandparents themselves, just living through their aging and just being around illness and death and senior citizens from, a very early age, from 3 on. And then kind of when my grandparents started to have illnesses and deaths, there was a progression of how they died. Um, and I kind of saw this journey of each grandparent dying in a very different way that really kind of affected me profoundly.
Can you talk about your grandfather in particular? That was sort of like in a sense, a culmination of a good death.
So my grandmother had died 10 years earlier in kind of the worst case scenario. And my grandfather had a full decade of life. But he started to lose his sight, and he was an avid reader, and he had kind of progressively lost his hearing. He did not have a terminal illness, but he really started to feel that at the very end, his life, he couldn't do the things that gave his life joy and meaning. And I was pregnant with my first child, and he kind of was just declining in a very general 95-year-old way, and had kind of helpers, but not officially was in hospice because he didn't really have a diagnosis other than being 95. So my daughter was born, and he wanted to make sure I was okay and she was okay, and he saw pictures. And then he promptly, in his very disciplined way, the way he led his whole life, stopped eating and drinking and lived for 3 weeks, the last 4 days in an inpatient hospice setting in Fort Lauderdale, overlooking the ocean with his daughters at his bedside, knowing that like we were all okay and that his great grandchild had been born. And then, he just kind of drifted off and very peacefully in hospice. And um, I mean, just like a beautiful sense of choice, um, and without suffering. He was ready. And not everyone that I take care of is ready. And I think I approach my work with kind of a non-attachment to outcome and without agenda, because it really is learning about what individual people's hopes and fears and values and meaning and um and many people are not ready to die or have not lived a life till 95. Um,
Yeah, but there's so I've in my congregation, there's a woman with I'm very close to her, and she is old and she's sick, and she is like many, many people, very, very nervous about dying. And we've discussed this. And I do wonder, even though you want to not have that judgment or place a value on other people's lives and decisions, from your perspective, would it be helpful for individuals in our society to be more ready in a sense, particularly when they reach stages like your grandfather reached and like my congregants and other people that I know that we've all known have reached, where we're like sort of clawing at life well beyond the point that we can do the things that we love doing. And I wonder if it's just a social thing, like it's
mhm.
part of our society that we just do not want to let go. And I'm also trying not to be judgmental about it, but I do wonder if we ought to be have a little bit more, I'm not sure the right word, acquiescence or magnanimity about this inevitability and to be comfortable choosing our time.
Yeah. No, it's really a complex question. I think what I think about this historically, when we had communities and didn't have all this advanced technology, and people died in their homes with the family doctor, with the home visit. It was almost like there was a practice of palliative care and end of life care that was part of the lifespan of the community, and that people, we didn't have nursing homes, and people took care of each other throughout the lifespan. And so I think there might have been a level of acceptance and comfort with death, even though, obviously the mortality rates and lots of things were very different then. But with technology has come this like gathering of sick people in hospitals and nursing homes. And so you don't go out into the world, and you're not visiting people's homes where they have people who are sick. It's very like, you know, shut off into these buildings and into these silos. And so I think that there was a period of time where, as we separated illness and aging and death from the healthy and the people who weren't worrying about this, it became easier and easier as a healthy person to pretend or to just not have experience the other side of living, right? Which is, we're all going to die and mortality is a part of living. So I think that technology is wonderful and public health is wonderful, but that there's been some sacrifice in community around death and dying. So part of palliative care's work is, we talk about advanced care planning, we talk about goals of care, we talk about people's thoughts about, if and when somebody's at the end of their life, what that might look like for them. And some people say, do everything until the very end. I want intubation and CPR, and I don't care how old I am. And our job is to say, yes, and how can we support you in those goals? And for me personally, I think I don't know, I think I'm a very self-regulated person, and then I've developed practices over time to show up very calmly and with like true authentic care and presence and do a lot of listening and be very comfortable with silence. And when people say, no, like, what are the other options? I can say what those are and what those look like, and can explain what comfort care is, and can explain how we take care of people when symptoms get worse. And so I can do a lot of things to address fear and anxiety because palliative care could do so much to not just mitigate suffering, but to help people live well with hope, even in the last moments of their life.
Right. Have you been in a situation where you have wanted to say, I know you address these concerns when they come to you, you kind of respond to them. But have you been in situations where you've wanted to be more proactive and at least wanted to say, or did say, there is another option for you?
When there are transitions in patients' clinical status, or when there's recurrent hospitalizations, or things are kind of not going in the direction that people had hoped in terms of, living well, but also kind of longevity, then I'm not shy about bringing up other pathways and talking about what a comfort focused only approach looks like, or I'm not shy about that. I think that I do it with permission. So I'm always asking, it seems like we might be in a different place. And would it be okay if I talked about, sometimes I frame it again in worst case, best case, likely scenarios, or, have you ever had discussions about when you are at the end of life, what kind of care would be most meaningful to you? Um, and sometimes it's really surprising. People have been on this course of everyone assumes everything to be done until the very end. But when you ask the question with permission, somebody might say, "Oh yeah, my husband and I have had that conversation. And no, if I'm at the very end, I would not want this and this." And it's just that the question has not been asked in the way that allows for, oh no, oh, that's what you're talking about. No, no, we've totally talked about this, or I've really thought about this, and these are my thoughts. And sometimes it's, whatever based on cultural, spiritual, religious, personal history, um, whatever people think that they want, I'm here to support them.
For my work, I'm dealing with these kinds of issues too. And as I'm doing funerals or having funeral meetings or visiting very sick people, I am also thinking about my mortality often, but not always. And sometimes I'm amazed at how I'm not thinking about my mortality. Like, why wouldn't I be thinking about my mortality when I'm in a meeting with a family with a loved one who just died? Does this work lead you, Tara Coles, to think about your mortality much?
So I don't think about my mortality very much. I think it's due, first of all, I've had two or three life-threatening medical illnesses myself that I have survived, and I feel very lucky to have done so. And so there's a part of those experiences that just, I think, have generated a way of moving through the world that's just full of like gratitude. And so I really don't think about my mortality. I don't have that like identification with patients and families that are going through these difficult situations. I very much know that it is not my journey, but I am helping accompany them along their journey. And so it just feels very natural to me to not like over identify, and I'm able to have empathy, which is compassion in action, without having the traditional kind of definition of empathy of like feeling with, right? So I can recognize the sadness and the grief and truly empathize without having it evoke the feelings in me of grief and sadness and fear of mortality. So I would say that the answer is really no. I have a sense kind of globally about mortality because I'm dealing with illness, death, and dying, and grief, and bereavement, and fear, and spiritual and existential distress every day. But if anything, it feeds into my own sense of gratitude about the joy of my family and the majesty of parenthood and um, kind of the cliche of quality time, but really, like, I very much appreciate the time that I have doing the things that I'm lucky enough to be healthy enough to do. So, if anything, I think it feeds my gratitude. And I think the sense of being able to appreciate my life then allows me to be at work and be completely other focused. And that brings me joy in my work. Because I know that my work is always making something better, that my presence and my care, I can't fix, I can't cure, I can't solve death, but I can listen in a way that makes people feel heard and understood, and I can manage people's pain and shortness of breath and constipation. I can make them physically feel better so that they can experience all the other facets of their life no matter what's going on with their bodies. And that it feels like a tremendous like privilege to be able to do.
Got it. I appreciate that. So this last question will make you think about your mortality. So as you, Tara Coles, lay on your deathbed, your final moments, hours, days, what song might you want to be hearing?
So the song that I picked, well, first of all, I'm from Long Island, so I'm a huge Billy Joel fan. Um, and one of my favorite songs is a lullaby that he wrote for his one of his daughter. And it talks about the rocking to sleep of his child and singing this lullaby, and that he will go on in her heart, and that everyone will be gone at some point, but the lullabies go on. I think about that lullaby like as memories, right? So my grandparents live on in my memories and in my heart and in my like expansive and ongoing love for them. And so I kind of picked this song because I can imagine myself hearing the piano bars and like recognizing, okay, that this is my time and feeling a peace because I know that the love and the memories and the connections with my children, with other people in my life will be the way that I feel like I will go on. And so that gives me comfort.
That's awesome. Dr. Tara Coles, I appreciate this, and I thank you so much for talking to me on Unveiling Death.
My friend, Rabbi Jeffrey Weil, it is a true pleasure, and I get inspiration by your work. And, it takes a village to take care of people across their lifespans, and we all need each other. Um, so I appreciate you very much, and I'm honored that you asked me to be part of this.
Thank you. Many thanks to Dr. Tara Coles. Thanks, as always, to my creative director, editor, and son, Sammy Weil. Please share this and other Unveiling Death episodes with your family and friends. And please follow the podcast as well. Thanks to my band, the Night Owls of Chicago, for the music you are listening to right now. Coming to Montrose Saloon on November 23rd, 2024. Contact me at rabbiw14@gmail.com. And thank you for listening to Unveiling Death, Eternity in about 24 minutes, every other Monday.